Welcome to Broad Eye, the podcast that explores knowledge gaps in ophthalmology and eye care. Hello, everyone, and welcome to another episode of the Broad Eye podcast. My name is Sean Maloney, and today I will be speaking with Dr. Charles Wykoff. Dr. Wykoff is a surgical and medical retina specialist. He has a number of titles, so we're going to let him introduce a couple of those, but he's based at the Retina Consultants of Texas. So Dr. Wykoff, welcome to the show.
Sean, great to be here with you. Yeah, I am a medical and surgical retina specialist, but really heavily involved with clinical research. It's an exciting time in ophthalmology, and it's only getting better for patients.
Yeah, no, for sure. And we're going to definitely dive into some of your research that you've been involved in. It seems like you wear a number of hats in both the clinical and research setting. But before we do that, I was hoping we could start off with a 50,000 foot view of diabetic retinopathy, and what is diabetic retinopathy? How does it develop? What are some of the risk factors, et cetera? If you could maybe talk to that a little bit.
Yeah, I appreciate that, and appreciate the ability to sort of have this conversation with you. Such an important topic. Diabetes, if you look broadly, causes a lot of blindness with a capital B, and that's not a word that I use lightly, because I see it every day, and every ophthalmologist sees it as well. And what's really frustrating about that is that these cases of blindness don't need to occur. This is preventable and avoidable. This is needless blindness. So the blindness from diabetes really doesn't need to occur. So when you see it, it's particularly painful because if the patient had just gotten the care that they needed and deserved earlier, they probably wouldn't be blind. Now, of course, you can't say that with 100% certainty, but we know that you can dramatically change the development of blindness from diabetes if patients just get screened and just get treated earlier in the disease course. I'll make just one example of that. So there's a lot of good data now, published data out of England and Wales and Iceland and some of the Scandinavian countries showing that when they implemented successfully screening programs for patients with diabetes to look for the retina manifestations of diabetes called diabetic retinopathy, they saw the rates of vision loss and blindness from diabetes go down dramatically over time. And so it works. Screening really works. So just a plug, if you have diabetes, if you have patients with diabetes, if you have family or friends with diabetes, which we all do, please make sure they're getting the eye screening that they deserve. Because now if we get into the details that you talked about, right, the eye is sort of the tip of the iceberg when it comes to diabetes manifestations in the body, right? People with diabetes, they can feel fine. They can have no symptoms at all and have quite severe and extensive eye problems from the diabetes. So you can't use symptoms or you can't use someone's vision to determine if they have significant eye pathology that needs treatment. They've got to get screened. They've actually got to get someone to look at the inside of their eye, at the retina. And then you asked two more great questions related to this. What are the risk factors? And then, so what does it look like? The risk factors are many. The big ones are what I call the cardiovascular risk factors. So blood sugar, blood pressure, cholesterol control. And it's not just, hey, I feel fine. No, but the numbers really need to be in range and as low as possible in most of those situations within a healthy range. The other ones are duration of diabetes. So for example, the longer someone has diabetes, the more likely they are to have diabetic retinopathy. So if you look 20 plus years down the road after diagnosis of either type 1 or type 2 diabetes, it's well over 80%, and in some cases approaching 100% of patients will have diabetic retinopathy. So the last thing I would say is this is really a when problem, not an if problem. If people live long enough with diabetes, they are going to develop diabetic retinopathy, whether they want to, whether I want them to or not. It's just a matter of getting screened and getting access to treatment early.
Oh, I think that's a nice overview, and I think we're going to certainly touch on that in a moment when we talk about a recent research study that you were involved with or helped oversee. But I was hoping you could touch a little bit on proliferative versus non-proliferative diabetic retinopathy.
Yeah, thanks for bringing up the details here. So in about the 1980s and early 1990s, there was a quantitative scale that was developed so that we all could talk the same language about the severity of diabetes in the retina. Right? So if we back up, the retina is obviously the light sensing part of the inside of the eye. It's essentially an extension of the brain that coats the inside of the sphere of the eye. And it has a tremendous amount of blood flow, right? When we sit down and we watch TV and we think we're relaxing, we are, but our eyes are actually working overtime. It takes a lot of energy, sugar, metabolites, oxygen to see and the processes of visual transduction. And therefore, it's sort of believed that the vasculature of the retina is particularly sensitive to chronic fluctuations in blood sugar, blood pressure, cholesterol control. And once you begin to have damage to the retina, then you can actually see changes of diabetic retinopathy. And those changes involve little microaneurysms, hemorrhages in the retina, changes in the pattern of the vascularity, and then ultimately proliferative diabetic retinopathy. So what that means is that the non-proliferative stages are when you get these changes within the retina, little hemorrhages, for example. And then once that progresses beyond severe non-proliferative diabetic retinopathy, you get what's called proliferative diabetic retinopathy, where you get abnormal blood vessels that grow in a process called neovascularization or angiogenesis. You get pathologic blood vessels that begin to grow outside of the retina. So they break through the surface of the retina and they grow into the middle of the eye, into the sphere of the eye, into what's called the vitreous of the eye. And when those small blood vessels begin to grow, at first they're sort of harmless, but then over time they get larger, they recruit scar tissue. Those vessels are friable and easily broken, so they can bleed and cause what are called vitreous hemorrhages, which can fill the sphere of the eye. And they also can cause traction from their associated scar tissue, ultimately leading to retinal detachment and blindness that way. So there's non-proliferative stages, which are often asymptomatic, and that's where you want to find patients with diabetic retinopathy. And then as they progress into proliferative diabetic retinopathy, those stages can also be asymptomatic, but that's when patients often begin to notice floaters or distortion in their vision as those abnormal blood vessels begin to grow and distort the normal retinal architecture.
No, wow, no, that's an excellent overview. Thanks for that. So just a couple of questions that come to mind. In the course of managing this disease, okay, I guess A, how, what are some of the treatment and management approaches, and B, do any of those overlap with other conditions that involve, a neovascular element like, neovascular AMD? Can you use anti-VEGF therapies in these cases as well, or is that not really the gold standard?
Yeah, great question. And to just back up a second, so we talked about proliferative diabetic retinopathy, which is one of the main ways that diabetes causes blindness. But the other big one, just to mention it, is diabetic macular edema. So you've got, you've got the proliferative disease, you've got diabetic macular edema. Both of those cause blindness from diabetic retinopathy. And DME, is, if we use the abbreviation, is when the retina, instead of being a dry, compact, multi-layer structure of cells, becomes boggy. It sort of gets like a wet sponge. And the retina begins to dysfunction, the neurons begin to break down, and eventually you get sort of loss of function of the tissue. So both PDR and DME are what cause sort of the vision loss ultimately and blindness from diabetes. And you put your finger right on the sort of most commonly used management strategy for both of these disease processes, if you combine them, which is pharmacologic therapy. So we have medicines that we inject inside the eye called really anti-VEGF pharmaceutical agents that block a very important growth factor that drives the pathophysiology of diabetic retinopathy and contributes substantially to DME and PDR development and progression. And these pharmaceutical agents have been truly amazing. They are revolutionary in their ability to treat diabetic macular edema and PDR, highly effective. Their biggest challenges are you have to put a needle in someone's eye, which is a big deal. And the field does this a lot. It really should not hurt, but it is a big deal if you're the patient and you're being told you have to put needles in your eye in the clinic. And the second major challenge with them is that they're not a cure. So most patients need repeated treatments over many years, in some cases indefinitely, which can be a lot. And on average, patients get, after the first year of dosing, through years 2 and beyond, probably somewhere between 3 and 6 shots on average a year in their eye. So it's a lot. It's a big burden for patients. But just to reemphasize again, their efficacy and their safety are very, very strong, highly effective at preserving vision and improving vision in many cases, and also proven to be extremely safe over a decade of use extensively across North America and around the world. And then to your other question, what's fascinating about this class of medicines is that they work for multiple different eye pathologies. So the most common reason they're used is actually not even diabetes. The most common reason they're used is what you said, which is neovascular age-related macular degeneration, because the same growth factor that drives DME and PDR also drives wet AMD or neovascular AMD. But the list doesn't stop there. They're also used extensively for retinal venous occlusive disease, which is the second most common retinal vascular disease after diabetic retinopathy. Of interest, sort of a subpoint, neovascular AMD is not considered a retinal vascular disease because in most cases, the new blood vessels actually come from the choroid, which is the layer sort of just outside of the retina in the structure of the eye. And there's many other diseases that we use anti-VEGF therapies for also routinely in the clinic. So they are incredibly effective, and particularly effective when you catch patients early in the disease process of diabetic retinopathy and DME.
No, for sure. And I think that anybody who has some background in this knows that these were really birthed out of some cancer metastasis research, right? With starting back with Avastin back a number of years ago, and then certainly found home in eye care. So I was hoping to dive a little bit into, a research paper that you were involved in, which, had some, I would say impactful findings talking about the initial or the severity of diabetic retinopathy at initial diagnosis and, risk of severe blindness. So maybe you could just say a few words about that and what the findings and impact of that study are.
Yeah. It's sort of a passion of mine, and of course, many people that work in this space, to sort of move the needle across North America to earlier screening, earlier intervention to prevent these needless cases of blindness, because we have such great therapeutics nowadays, these people don't need to go blind. And so sort of an open question for us in the field, and where this paper sort of came out of, was the concept of, okay, we live in this world where we have great therapeutics for diabetic retinopathy, non-proliferative stages, proliferative stages, DME. We can treat these patients if we catch them early enough. But yet still people are going blind. And so, right, what is the role of baseline diabetic retinopathy severity? In other words, how severe the retinopathy is at presentation. What's the role of that characterization with the ultimate risk of going blind? And the other sort of context here is, right, traditionally, before 5 years ago, the only way to get retinopathy screening for patients with diabetes was to go see an optometrist or an ophthalmologist, someone that actually does eye care. But what's fascinating is the proliferation of all of these technologies that are allowing screening at PCP offices, endocrinologist offices. Ultimately, I hope you walk into your drugstore or your gas station. You can get an eye picture that will help screen you for diabetic retinopathy. That's ultimately a big goal, I think, where screening can be performed outside of physicians' offices. But today, there are FDA-approved, FDA-cleared devices for screening for diabetic retinopathy without the presence of a physician, which is great because it allows increased access to screening. And so the question is, based on something you could identify from a fundus photograph, based on the severity of diabetic retinopathy, can you then predict over time the risk of blindness? And the answer from this work was a resounding yes. And what we did was we looked at the largest ophthalmology registry available. It's called the IRIS registry, which stands for Intelligent Research in Sight, or IRIS. This is sort of shepherded by the American Academy of Ophthalmology, or the AAO. And it is a very large database that holds information from approximately 60 million unique patients. It represents over 2/3 of practicing ophthalmologists across the United States. It's a very large database that's derived from the electronic medical records of these physicians and these patients. And so we mined this IRIS registry for patients presenting with diabetic retinopathy with good vision over a few years, and then looked at their outcomes. And we were very specific in sort of the patients that we included in this. This wasn't just to look at all patients presenting with diabetic retinopathy. No, we only wanted to look at patients that had a new diagnosis of diabetic retinopathy. And so the way we did that was we had a lead time. These patients had to be in the registry without diabetic retinopathy, and then develop diabetic retinopathy, and they had to have at least an 18-month lead time without the diagnosis. So we're pretty confident these were new diagnoses of diabetic retinopathy. And then also they had to have good vision. So they had to have 20/40 or better, which is essentially normal functioning vision. And they also could not have DME, which is the most common cause of vision loss from diabetes and diabetic retinopathy at baseline. And they couldn't have a whole host of other ocular comorbidities. So we were trying to be very specific, looking at a group of patients with newly diagnosed diabetic retinopathy without other eye problems and with good vision. So we're sort of stacking the deck against going blind. And then we looked at outcomes over time, and I can go into those if you'd like.
Yeah, if you don't mind, just to comment on that, because I think the whole findings of this are certainly informative for the field and for the people seeing these patients.
Yeah, absolutely. So then the main outcome we were looking at was this development of what we called sustained blindness, which we defined as 2,200 or worse at 2 or more visits, and without really substantial improvement at any time in the record after going blind. And then the exposure of interest we looked at was again their diabetic retinopathy severity at baseline or at index. And we broke that down into sort of 4 clinically relevant categories. We had mild non-proliferative diabetic retinopathy, moderate and severe, and then PDR. So we had 3 categories of non-proliferative diabetic retinopathy and 1 category of severe. And really there's very good data historically showing that if you have PDR, your risk of blindness is substantially elevated compared to others. And so we're sort of most interested in these NPDR patients, because sort of traditionally, clinically, you think of these patients as asymptomatic, they're walking around, they think they're fine. These are the people you really want to get into screening. And what we saw was a very clear relationship with baseline diabetic retinopathy severity and the ultimate risk of becoming blind over time. Average follow-up here was between 1 and 2 years, and ultimately a small percentage of patients in the entire population went blind. So we started off with about 53,000 eyes, 53,535 to be specific, and only 1.3% of them went blind over sort of a 1 to 2 year follow-up period on average. In some cases, we had up to 4 and 5 years of follow-up, but on average, it was about 1.5 years or 2 years of follow-up. But of those 1.3% that went blind, there was a clear increase in that risk among patients with more severe stages of diabetic retinopathy. And the specific numbers were that for eyes with moderate NPDR, severe NPDR, and PDR at baseline, their risk of developing blindness after 2 years compared to eyes with mild diabetic retinopathy at baseline were 2.6, 3.6, and 4-fold greater. So by having sort of severe NPDR to PDR, the numbers are remarkably similar, between 3.5 to 4 times more likely of developing blindness over time. And this is, this data set is captured during the anti-VEGF era, right? So we have these pharmacologic agents accessible to us, and yet still a meaningful proportion of patients that present with a new diagnosis of diabetic retinopathy are going blind. And that baseline severity level is quite meaningful in predicting that. And so what this does is it kind of empowers physicians broadly to say not just eye care professionals, but it empowers really all physicians that see patients with diabetes. Hey, look, you really got to get screened. And not only that, but your baseline screening can be highly predictive of your risk of blindness. And if you have a more severe stage, even if you don't need treatment today, be careful, be extra careful, because your risk of blindness is increased compared to what it would have been if you were identified at an earlier stage, even if you're asymptomatic with good vision.
No, I think that's it. There's a lot of things like I want to jump into there, but I'll cherry pick a few. But you're talking about, the increased risk when people have PDR, but you're also only talking over a short time frame, like a year and a half, 2 years. If you look at what is the risk of going blind if you first present with PDR over 5 or 7 years, like those numbers are going to be significantly higher, right? So someone
Great
thinking,
point.
oh, hey, so I think it's something. It's important that, any patients or families of patients that would be listening to this thinking, oh, hey, there's only 1% of people in the study who went blind. And there was more, more of those are people that had PDR. That's still pretty low. Yeah. But if you look at this over a 5 or 7 or 10 year period, those numbers would be astronomically higher. So it's something to keep in mind. You mentioned the anti-VEGF. Is laser used at all in treating these patients?
Yeah, great point. I want to address both of those things. The long-term follow-up is such a critical point that's often glossed over. I'm so glad you brought this up. This is very much a chronic disease. And I sort of emphasize that to the patients that I see. I'm like, look, there's no cure for this. This isn't like just do this one-time treatment and you're done in most cases for diabetic retinopathy. So I really encourage patients and family members out there, find a physician that is convenient to see. By convenience is a big factor in getting patients to go back, and also that you like and respect. Really important that you have a good eye care professional that's comfortable diagnosing and managing the eye problems that come along with diabetes, because there are great treatments for this and patients don't need to go blind. And the cumulative development of blindness is very real. So we saw separation of the curves in this analysis as early as 1 year and before, but then to your point, the numbers just increase over time. That's one of the reasons why I get frustrated with sort of snapshot cross-sectional epidemiologic analyses, because it's the long-term risk that's the most important. And if you follow patients long enough, their risk of developing meaningful diabetic retinopathy that needs treatment becomes very high over time. And then your second question is a great one, which is, well, okay, how do we really manage this, right? Is it always pharmacotherapy? Are we always injecting medicines in the patient's eyes, or is there something else? And there is, right? The lasers for diabetic retinopathy work very well, and they've been validated now since the 1980s and even earlier for pan-retinal photocoagulation. And for PDR in particular, PRP or pan-retinal photocoagulation has been validated and is very effective. The value of using PRP, which is basically targeted ablation of the peripheral retina, is that you're having a permanent effect. It's not a cure. Many of patients that get PRP will need ongoing treatment, potentially for PDR or possibly for DME or other problems, but there is a permanent effect. So there's a little bit of a safety blanket there in case there are challenges with access to care, or difficult to get into a doctor, or insurance is lost, or patients move to an area where they can't access care. So especially among our highest risk patients with PDR, I do think that laser still plays a really important role to be considered in the management of these patients. Now, there's pluses and minuses with any intervention in medicine, and the pluses of the medications that we use by injections in the eye are that they don't damage the retina that's there currently. There's no ablative effect. You're not killing tissue, to be blunt about it. The problem with the medicines are what we've already talked about. They don't last. They're not a cure. There's no permanent effect. They wear off, and the patient will probably be back where they were at severity level if they're not retreated over time. There are some caveats to that we get into, but I'll leave that for another discussion. The benefits of PRP is that it's durable. There's a permanent effect, but the biggest downside is that you're essentially killing some peripheral retina, and you can have symptoms from that. You can have night vision problems, you can have contrast sensitivity problems, color vision problems, visual field problems, and all of these are well documented. So it's definitely not a one size fits all for all patients with diabetic retinopathy. There's multiple options. We haven't even talked about the steroid treatment options, which are highly effective in this disease process as well. So it's worth a conversation between the provider and the patient to figure out the best options for management. But the key is there are multiple options, and they combined, when used in the appropriate way for patients, are highly effective at restoring vision in many cases, and certainly at preventing blindness when patients receive early access to care.
So, when, so Christina, who helps me with one of the people who helps with this podcast, when she was saying, hey, I got Dr. Wykoff to be part of the show and it'd be great. One of the things that came up in a discussion was, when you look at the results of the paper that you published, what is alarming to me, and I had this discussion with her, is how quickly somebody, who presents with PDR, for example, how the risk of going blindness in such a short time frame. And I think that's a real take-home message for patients and clinicians alike, is that it's not like, oh, hey, they're going to present with PDR and they'll probably be fine for 5 or 10 years. And then, it's just a slow growing thing. Once you get to that point, the irreversible damage can come on very quickly. And, which really just screams to the point, which is really what the paper is saying. Like, people need to get screened, and they need to get screened regularly so that this can be caught early, so that, this is a largely preventable form of blindness. Now, is it the same case? Like, your data was generated from a U.S. population. Is it the same thing, you would assume, or is there data out there in some of these other regions? Like, you had mentioned Iceland and England, I believe it was, and other regions. Yeah. Are there data sets there that have yielded the same thing, or is this study with the U.S. population, the first of its kind, at least on this scale?
Yeah, it's a good question. And the IRIS registry is so unique because it is such a huge collection of data representing many ophthalmologists and 60 million unique patients. So it really is a unique registry, and it allows us to ask questions like this that are unique. But really, while this is a important study, I'm privileged to be a part of it with a great team doing this, it's actually really, if I could say this, less important than the real world data that people are generating showing screening really works. Like, I really applaud the teams in England and again Europe that have demonstrated that, hey, they can take blindness from diabetes, number one cause of blindness in working age people from age 20 to 65, and they can make it so that diabetes is no longer the number one cause of blindness. Actually, the number one cause of blindness in the UK now are inherited retinal diseases. It's no longer diabetes because of the effectiveness of the screening programs. So huge kudos to those teams that have shown that, and the teams that are making that happen on a daily basis, because there's so many patients with diabetes and they deserve to get screened. And Sean, you and I, we walk around, we're busy. Like, if I had diabetes, I could easily see how I would say, I can see, I don't have a problem. I don't need to go get my eyes screened. I'll just wait till I'm symptomatic, right? And we see that all the time. So please, if I could have 2 call outs, one to patients and families and friends of patients with diabetes, it represents all of us. Please encourage people with diabetes to get screened. It's non-invasive, it doesn't hurt, there's 0 risk with the screening process, and you so deserve it, because vision is so important, and it can be much harder to get it back once it's lost than it is to preserve it from the beginning. And secondly, as providers, if you're a primary care physician, if you're an endocrinologist, if you see people with diabetes, I would really encourage you to begin to look into the technology that can do screening exams in your office, right? There are these camera systems now that you can rent or buy or whatever, and you can put in your office, and you can do screening for diabetic retinopathy in your office without an eye care professional, which I love, because it really allows us to expand the points where patients can get access to screening.
So you brought up a couple of things there. One was, I had briefly touched on it earlier, but you kind of hit that point, was that, patients are thinking, hey, I won't bother getting screening until I have symptoms. But, that's the other thing that came out of your study, is that by the time someone has symptoms, they could have a very advanced disease, which is quite scary, right? So that's definitely something for people listening to this, and even people who are, medical students or residents or physicians in other spaces that are listening to this to be aware of. It might be too late at that point in time, or largely too late. The second thing I wanted to touch on was, so what is it that Europe and other regions have done so well in the implementation of screening that maybe the US or North America is maybe a little bit behind on? Like, what do you see as necessary steps to, make this, other than just the education side of it, the necessary steps to, to put this screening in large scale into practice? So whether that is screening that's happening at, their family doctor, the family physician's office, or in, like you said, maybe eventually in a pharmacy or elsewhere. What do you think is necessary to, to really make an impact in over the next decade, what they've done in other locations?
Yes, super important question, and I wish there were an easy answer to that. I think the approach has to be a multi-pronged approach, right? You have to continue to work on education. This needs to be a national initiative, right? This needs to be something that all physicians get behind, right? Blindness has so many downstream effects. There's so many papers over years and years showing this, right? Blindness doesn't just affect the person that's blind, of course. It takes them out of the economic engine of a given, area, a given country. It sort of makes them more dependent on others. It can actually drag down the economic productivity of their family and their social group, because people are helping them when they might otherwise be working. It can certainly have negative physical effects on the person that's blind. They might exercise less. It can have negative emotional and psychological effects on the person that's blind and the people around them that are blind. So huge implications locally and beyond about the numbers of patients that are blind. And so really needs to be a national initiative to minimize blindness. And the easiest place to do that, the lowest hanging fruit, is diabetes, because the treatments are readily available, highly successful at preventing and treating blindness. So it needs to be a national initiative. Secondly, it needs to be, well, I'm an eye care professional, and we've always said, look, you got to get your screening, go see an eye care professional once a year. That's great. I mean, if people can do that, I think that's still the gold standard, but we need easier ways for people to get access to screening. So like you mentioned, that we talked about before, sort of imaging modalities, right? Eye care is such an elegant specialty, and I'm so fortunate to do it because it's so beautiful. We get to look at these amazing retinas in the back, and it's such an imaging-based specialty. So there's no reason why non-invasive cameras can't be used to screen for diabetic retinopathy at anywhere you can think of, movie theaters, malls, whatever. Just like when you walk into a drugstore, you might see a blood pressure cuff where you put in a dime or a quarter or whatever, and you get your blood pressure measured. Well, there's no reason that technology couldn't be implemented for diabetic retinopathy screening as well on a population basis. And then, third, and probably the most complex of all of these, is the payer system, right? So you've seen these big changes in places across the Atlantic where you have single payer systems that are able to make it an initiative and really a mandate for physicians and patients that they really have to get screening. It's no longer sort of an elective part of it. And so I think we're a long way off from that, at least in the US. You guys in Canada may be a little bit closer to being able to mandate something like that. But I think it's a multi-pronged approach, and education's got to be the foundation for all of the approaches.
Before I want to just dive into maybe one more topic before we wrap up. I appreciate you taking your time here. But you're talking about the whole point of the conversation is really hammering home on the early screening and detection of diabetic retinopathy. And there are other eye diseases also that can benefit from everything could really benefit from early detection, let's be honest, right? And the eye is, other than, let's say, the skin, and looking at dermatology, the eye is probably the ophthalmology, I guess, would be the most accessible discipline for imaging technologies. What do you think the next 5-10 years holds? Do you think that I will be able to, hold my smartphone in front of me, it's going to, be able to detect where my pupil is and, hold still for a minute and take a fundus photo that could be, uploaded to the cloud and automatically screened, or using either sent to somebody like you in Texas when I'm sent from Montreal, or like, are these technologies on the horizon, you think? And if not, then what do you think is up and coming in the diabetic retinopathy space?
Yeah, it's a good question. I think that two thoughts there. Yes, I do think that the imaging of the inside of the eye is going to get more accessible to people. I don't know if we'll be able to directly point your iPhone, just given the optics of the eye. But I do think in the near future, you'll be able to buy little adapters on Amazon that you clip onto your phone and then point it towards your eye and get a picture of the inside of your eye. So things like that are going to be very possible in the not too distant future. And then, yes, I think there will be software systems available where you can upload your own images and look for pathologies, databases that will match your image with other images that are out there. So I think those things are coming. The other thing that this branches into is the utility of ocular imaging for other diagnoses, right? The eye is very much a window into the entire body. And there's good papers already showing that based on a fundus photograph, there are software systems now that can predict highly accurately a patient's blood pressure, a patient's smoking status, a history of a cerebrovascular event. They can even predict things like gender status. Is it a male or a female patient? And no ophthalmologist or optometrist in the world knows how to do that, looking at a fundus photograph. So there's a lot of information in these images that we've been looking at for years. And there's a lot of really sophisticated software algorithms being developed to not only think about diabetic retinopathy and the risk of going blind, but also diagnosing many other diseases, including things like Alzheimer's disease and many others. So I think we're going to see ocular imaging in general, and specifically retina imaging, play a much more important part in a lot of angles of medicine and diagnosis and prognostication over the next 5 to 10 year horizon.
No, I think, I heard something in a recent interview I did with, I don't know if you know Professor John Nolan. He's at the national. Yeah. So he's, very well known in ocular nutrition. And he was highlighting that, I think it's the concentration of macular pigments is actually seems to be correlated with, Alzheimer's and dementia's progression. So it's like you said, the eye can be a real window to health in general. So I think that having good imaging of the eye and make that broadly available, and then have that probably disseminated to physicians to be able to make diagnoses, or eventually have artificial AI or machine learning applications that can render diagnoses and just send the referrals to people like you. Say, okay, this person here is this is their situation, here's the automatic referral, and set up an appointment. And I think that would be nice to see, and make the field move a little smoother. But is there anything else you'd like to add before we wrap up? I mean, it's certainly I think we've covered quite a bit.
Enjoyed the discussion, Sean. Yeah, that was fantastic.
Yeah. Well, listen, I appreciate you taking the time to speak with me about this and share your knowledge and perspectives.
Of course. Good luck, Sean. I appreciate the work you do.
And that concludes today's episode of the Broad Eye Podcast. If you enjoyed this episode, please be sure to subscribe on your favorite podcast platform. Of course, ratings and reviews are always welcome. And you can certainly share this episode with any of your colleagues or friends who might enjoy it. Thanks for listening.